Welcome to Fertility and Sterility on Air, the podcast where you can stay current on the latest global research in the field of reproductive medicine. This podcast brings you an overview of this month's journal, in-depth discussion with authors, and other special features. FNS On Air is brought to you by Fertility and Sterility family of journals in conjunction with the American Society for Reproductive Medicine, and is hosted by Dr. Kurt Barnhart, Editor-in-Chief, Dr. Eve Feinberg, Editorial Editor, Dr. Micah Hill, Media Editor, and Dr. Pietro Bortoletto, Interactive Associate-in-Chief.
Hello, and welcome to a new episode of Fertility and Sterility on Air. I'm the Editor-in-Chief, Kurt Barnhart, and we have a little bit of a skeleton crew this morning, but we're going to power through it. Hello, Eve, and hello, Adriana.
Hi, good morning.
Good morning. We are going to power through it, and we're sad to miss Micah and Pietro, but they will be back next month.
And because we're powering through it, you can power through it. And however you're listening to this, I hear lots of wonderful stories about people listening on the treadmill, on their way to work, whether they're walking their dog. My dog certainly loves the podcast. So I hope that you'll power through it along with us. So for those keeping score at home, we're doing the May 2024 issue, volume 121, number 5. And as always, although we're not going to cover them in fully, I really encourage you to read some of the other content in the journal. We have a views and reviews put together by Rob Norman, who does a wonderful job and has a great perspective on the field in general. And he put together a series of 4 articles on basically prophecy, prediction, and prognosis. He really went through our field in general, looking at unexplained infertility, embryo screening, menopause and premature ovarian efficiency, and success with IVF, each of those topics looking at how you may be able to predict it. So basically, it's a combination of mathematical models that have been published, but also good clinical acumen to say, can these things actually be predicted before they present to us? And if so, how? So I really encourage you to read all those articles, or particularly the one that might be of your interest. There's also a pretty good inkling that I might pass over to Eve. If nothing else, you should look at the title. An egg is not a chicken, an embryo is not a child. Eve, I think that begs a little bit of a question. Please give us a little background on that.
Yeah, so as I alluded to last month, it's been really busy with everything that's been happening with the Alabama ruling. And so this inkling was co-written by me, Nanette Santoro, Marcel Cedars, and Paula Amato. And it's really just thought leadership about the Alabama ruling and really discussing why it just is nonsensical from a scientific standpoint. And so title credit goes fully to Nanette Santoro, who thought of it. But I think it's really just a very simplistic way of putting it out there and saying, this is ridiculous.
I wish you to read that and pay attention to it. All of you listening to the podcast, I'm not here for political reasons, but science is our stick. I mean, we are reproductive endocrinologists. We should be speaking the truth and the scientific aspects of this debate. Fertility and Sterility is certainly a great forum for it, although we want to present the scientific underpinnings for all of our work, but also the scientific underpinnings of really strong opinions. There will be other editorials coming out on Fertility and Sterility about this topic. Please take a look at it. One of them, for example, will be how other countries have dealt with this kind of ruling. For example, the European model has had some of these restrictions in various forms in various countries, and how the practice of reproductive medicine has survived in those countries is also important for us to know. Well, let's move on a little bit. I also want to give a plug for the ASRM pages. Now, I think the ASRM pages are one of the strongest parts of this journal, and you can always go to Fertility and Sterility and find the practice bulletins and all the other aspects of the opinion that the American Society of Reproductive Medicine come out. But this one actually is not incremental change. This one is a real big difference, and you should pay attention to it. This one describes subclinical hypothyroidism in the infertile patient population, a guideline. And spoiler alert, the guidelines have really, really changed. We did a Journal Club Global on this, which was a big hit, and I encourage you to go onto online and find that rebroadcast of it. But in essence, we have been chasing down numbers for a long time, and I think the practice guideline really says that we should stop. So we should be managing people with hyperthyroid and hyperthyroid, but we shouldn't be chasing the subclinical hypothyroidism just to treat a number. That was a big release to my practice. We've implemented it easily. How many conversations do we have? What do we do with that thyroid? That's that TSH level that's 3.7 with or without TPO antibodies. I mean, the nursing time spent on chasing down these numbers was enormous. And basically the practice bulletin says, don't bother anymore. It's not helping. So please take a look at that. Eve, you were intimately involved in that. You want to comment on it at all?
Yeah, I mean, I think that it's really huge. And I actually was not involved in the writing of that document, but I think it's revolutionary. And I think that, really it's going to change. And I think it is going to make things much easier without any sort of detriment to patients. I think we've been over treating thyroid disease for a long time. The one thing I will say is that some of the papers that we based our original recommendation on were retracted. So they were based on data that were fabricated. And so I just want to give a huge shout out to all of the effort and work that's been going on behind the scenes with ASRM and the Research Integrity Committee looking at scientific integrity. And I think that we're going to see more and more of this in the future.
To translate that, there was one relatively large study that found a positive association that was found out to probably not have ever occurred. And when you remove that study, there basically is no benefit to treating subclinical hypothyroidism. And applaud to the ASRM for recognizing that once that change was made, you can change the entire guidelines. This is going to go down how sensitive our literature can be based on not so good science. So I'm glad we corrected that. Well, sit back. We've gone through all the administrative stuff. And the first article that I'm going to talk about, the seminal contribution this month, is really worth your interest from a very high level. It's from a very prolific author, well known to us, Eli Adashi, and his colleagues, including Dimitri Kissin and Ro Gutman from the CDC. And it's Iatrogenic and Demographic Determinants of National Plural Birth Increase. This is a history lesson for me and probably for Eve, for Adriana, and for other younger people. It's worth understanding that where we came from to really create and then solve this problem of multiple births in the nation. I know we all understand how medically complicated multiple births are, and it took us a long time for us to recognize that what we were doing in our practice and seeing, well, a twin pregnancy is okay, at least somebody got pregnant, was on a national level causing a real medical health crisis. And we had to actually, as a field, change the way we practice IVF and reproductive medicine to lower that. Probably I could fill with lots of anecdotes here. I remember sitting at a large black tie dinner in Philadelphia, and the media was celebrating itself for some reason or another. And one of the reporters said, "Isn't it lovely? There was another set of triplets that we put on the news." And it was my colleague Chris Huss who said, "And it's your fault. You're the one that's saying how wonderful this is and how miraculous it is. This is a medical problem." And it became a nationally recognized problem. And this article by Dr. Adashi is giving us a little bit of historical basis. So let me go through, again, a little more history before I get into the data. So ASRM has addressed this problem. They've recognized that plural births, or especially high order multiples, are a problem economically, health-wise, and impacts the whole nation. It addressed it in 1998 with the first guide for embryo guidelines. For embryo transfer guidelines. 1998 was the first time we actually said we gave guidance to how many embryos should be put back. And I remember being at the practice committee at that time and arguing in a room about that. And that was, kind of groundbreaking work. Now, that's been updated a couple of times, and the most recent in 2017. But the really important aspect there was in 2017, we changed the language, the Royal We, ASRM, from reducing higher order multiples to reduce all multiples. And this is kind of what this article is saying, is how successful we are doing this. By the way, the other really big change, if you've listened to this podcast, you've heard me into semantics, how much I hate unassisted pregnancy. But one of my other contributions that I'm going to put on my eulogy is I changed the terminology of ASRM from poor prognosis, normal and poor prognosis patients, therefore giving a stigma to everybody that had decreased ovarian reserve, to now the terminology is regular and favorable prognosis. So words do matter.
Kurt, you hate spontaneous conception, not unassisted
yes,
conception.
Of course. I can't even get my own words right. So what does this paper do? So this paper looks at the national surveillance data where you can see the plural births, how many twins were born, triplets and quadruplets across the nation. And it compares it to the CDC surveillance of IVF, which we all know contributes to around 98% of all IVF cycles. And therefore, they can see how many multiple births are associated with IVF. And if you do the math, which they do quite elegantly in this paper, you can subtract out the difference and also find out how many were due to ovulation induction. And there are some really, really interesting trends that I think are seen here. Please look at the paper for the math. It's done very elegantly with the Bayesian models and multiple imputations, and they have very tight confidence intervals. But basically, what they want you to learn, and I'm trying to tell you here, is just the trends. So in 1997, the plural birth was around 9.7 per 1,000 pregnancies. It went up to a high in 2009 of around 17.1, and then we've actually decreased it now, to late now being 2021, to around 7.7. So we have seen these lovely curves in this paper, which is basically an upside down U, where they've gone dramatically up for infertility, peaked in around 2009, and have come down. But there's some subtlety here. And the subtlety is that the plural pregnancy rates are changing. They're changing mostly because they're going down due to IVF, but they're going up due to ovulation induction, and they're going up in the older age group. Let me give you the take-home message. Basically, we're very good at reducing plural births with IVF because we've all accepted single embryo transfer, and now almost 80 to 85% of all transfers. But ovulation induction has about stayed the same and is still contributing to a lot of plural births. And the vast majority of plural births are now in women greater than 35. Now, that's a mathematical issue because the number of plural births in the women less than 35 is only around 50% due to assistance, but it's closer to 70, 80% in the older age group because those women are not conceiving multiple births unassisted. So I hope that wasn't confusing everybody. So let's go back to the take-home messages. In 1967, when Clomid was introduced, was the first time we saw really increase in plural births. In 1980, IVF really took hold, and we really saw an acceleration, 5-fold, 7-fold increase in plural births, reaching the peak in around 1987. Since 1987, we've decreased the plural births due to IVF, but OI has maintained. Interestingly, in my mind, and I'm going to ask Adriana and Eve, why do you think that is? Because we don't really do ovulation induction anymore for plural births. So we've reduced the twins and triplets due to OI and IUI. Yet, according to this records, the plural births due to ovulation induction really hasn't been touched. Have a theory about that?
I do. I would have loved to see these data looked at by state. And so I think that those who are in states that have some sort of insurance coverage do a really good job with elective single embryo transfer and moving to ART. And I think that the trends really are in those states where there's no insurance coverage or even patients that are underinsured in a mandated state, there's still a lot of gonadotropins that are going on. And what worries me is the trend of OBGYNs prescribing gonadotropins, those who are non-REIs prescribing gonadotropins. And what we see in our system at Northwestern is a lot of non-REI is where it accounts for the triplet births. And so I think that it is really a good push for insurance mandates and enhanced insurance coverage for ART to try to get some of these patients to utilize IVF and single embryo transfer as opposed to ovulation induction or superovulation.
That was going to be my thought as well, especially, surprisingly, California is not a mandated state. And we see many patients who get referred to us in our IVF clinic after being prescribed letrozole for 6 to 12 months by their OBGYN with having no monitoring throughout any of those cycles. So I'd be curious to see where these patients are getting their treatment and also how they were monitored during those cycles as well.
Okay, I agree with you both. I think it's probably more complex than that. I think it's two competing issues. I think again, in the early 2000s, when we did a lot of ovulation induction, we had plural births for that reason. They've come down, but I think more people are using Clomid outside of an REI's practice, which has come up. So I think that's contributed to what looks like no change. But I think the no change is due to multiple factors that just landed on no change. And I think that a lot of the plural births are due to non-REIs practicing or have limited ability to go to IVF. The paper, of course, now that I've told you these trends, does have a couple limitations. Most of the plural births are in white women. That's not surprising because of the racial disparity in who actually can get IVF. And as I mentioned, most of the plural births now, at least as a percentage, maybe not as an actual raw number, are in women greater than 35 because we're getting very successful in treating people that otherwise wouldn't have conceived unassisted on their own. Does that surprise you guys?
No.
Yeah.
I'm not surprised by that at all.
Yeah. Well, for those of you that, look at the twin strollers going down the streets and guessing if it's IVF or not, if it's a woman that's young, don't make the bet because it's still probably greater than 60% that it was an unassisted pregnancy. But if that woman is older than 35, your bet is pretty solid that baby those children had some assistance. Finally, the other limitations are, again, we can only take this on a high level. There's a lot of missing data in this area, especially in race and especially in BMI, whether we could argue whether those truly do have a differential effect here. But again, when you're looking at population data, you have to recognize that as sophisticated as they were trying to overcome this missing and misclassified data, there's going to be problems in here. So the story is, Adriana, what do you think of the story? Did I tell it well? The story is basically we have done a great job in reducing plural births due to IVF, but we have not done a great job of reducing plural births overall. While we've eliminated mostly the higher order multiples, we really still have a national problem of twins. Probably that's coming from ovulation induction rather than IVF.
Yes, great story. And I think it's really important for us to sometimes take a pause and see how we've been doing over the past several decades.
Yeah. I mean, one thing I want to point out, I do think we're doing a great job, but if you look at figure 3, where it looks at calendar year and the number of ESETs and the number of non-elective single embryo transfers, it looks like this really sharp rise up. But I just want to point out that the top end of the axis caps at 50%. So we should be at 100% ESET, or at least 80% ESET. And so I think that we still have a lot of room to grow in reducing that. Certainly, I think the lower hanging fruit at this point is ART because we can control that setting a lot more than we can control ovulation induction. But I think that there still needs to be more of an effort done on all fronts. But I think you told the story beautifully. And I just think it's, as we are getting further and further in this field, and innovation is not that it's stopping, it's slowing. I think the next step is really optimization of the things that we already are doing.
My final message again is this is where our practice, micro, the patient in front of you, where you want to do the best for the patient, in the macro can really affect public health. I mean, if you just focus on, I'm going to do everything I can for this patient, and I don't care about the consequences as long as she gets pregnant, that has a national problem. So we as a field, it's amazing, can really affect national demographics.
Yeah, so well said, as always. I'm going to take this next article. It is in the ART section, and the title of this paper is Comparison of Outcomes Between Intracytoplasmic Sperm Injection and In Vitro Fertilization with PGT for Aneuploidy, Analysis of SART-CORS Data. So I think this, again, was a nicely done study, and it adds fuel to the fire in the debate on ICSI for non-male factor infertility. And again, back to this idea of can we optimize what we're already doing? The aim of the study was to evaluate whether there were significant differences in the number of embryos suitable for transfer and the live birth rates with the use of IVF versus ICSI in patients without male factor infertility who are undergoing IVF with PGTA using the SART-CORS database. And the authors hypothesized that embryos suitable for transfer and live birth rates would not be significantly different between these two groups. And interestingly, they were inspired to do the study based on the ASRM position statement on the use of ICSI for non-male factor infertility, where the use of ICSI is recommended in the absence of male factor for embryos destined for PGT cycles. And just note this next sentence, where contamination of extraneous sperm could affect the accuracy of test results. I personally always thought that was only PGTM. So we don't typically do ICSI for PGTA in our lab. I was not aware that people were, but the authors state that these recommendations highlighted the need for more studies evaluating the necessity of ICSI and PGTA cycles. It was a retrospective cohort study from January of 2014 to December of 2017. They looked at all ICSI cycles and then all linked FET cycles. And there were two primary outcomes: the number of embryos that were suitable for transfer and the live birth rate. They had almost 4,800 IVF cycles and almost 26,000 ICSI cycles. And in my mind, not surprisingly, there were no differences in the number of embryos suitable for transfer or live birth rates between euploid embryos from IVF versus ICSI. I think they used some solid statistical methodology, including generalized estimating equations, to account for correlated data within a patient because of repeated measurements. And I think for our learners out there, I think it's important to understand that multiple IVF cycles or FETs in the same patient are not independent events and they cannot be treated as such. And so I think one of the largest criticisms that I always look at when I peer review is whether or not there was any accounting for that. And to me, the take-home point of this paper is that ICSI is not superior to IVF, and the use of ICSI should really be limited to male factor infertility. This comes up time and time again on this podcast, or to specific indications where ICSI will be beneficial. And my interpretation of that is really in the use of PGTM, although apparently that is debatable as well. And I also hope that in the future, the rate of ICSI will not continue to be 85% of all cycles. Now, one thing I do want to say, I recently had a case of a patient who had recurrent molar pregnancy, and that to me is one of the true indications for ICSI in the use of ART. And United Healthcare denied the patient's entire cycle because she, A, didn't have infertility, which she did, and B, because we were using ICSI for non-male factor infertility. And so I did a peer-to-peer, cited all these articles, gave the peer reviewer a bunch of literature to look at, and they still denied the cycle. So it was maddening. Like, I don't think it should be taken so far that ICSI absolutely cannot be used outside of the indication of male factor infertility. Kurt, Adriana, what do you think?
It's an ongoing debate. I can see both sides. We use ICSI, the royal we, far more than is necessary. And there's a lot of evidence that shows it's not helpful. In fact, in some cases, it might actually hurt, although the hurt is on a population level, not necessarily the patient in front of you. So we continue to use it. We get paid for it. We think it works. I can also see the insurance coverage think, why would I pay for it if there's not any information to use it? So it's one of these things I think we're going to be fighting out for a long time, even though I'm preaching that we overuse ICSI.
Yeah. And I think that anything in medicine, any recommendations that are like absolutist, I think harm us because there are always nuances or particular situations that don't apply.
So what do you think about the recommendation about using ICSI for PGTA in general? What did you think of that comment?
To be fair, like that was never my interpretation. And we actually do not routinely use ICSI for PGTA in our program. And when I read the original practice bulletin, looking at the wording of where contamination of extraneous sperm could affect the accuracy of the test, I really interpret that as PGTM, but I don't know. Kurt, do you typically do ICSI for PGTA cases?
So I'm proud to say that our lab has been very flexible. We used to, as a mandate, anyone that had PGTA got ICSI for the fear that you were contaminating the result. But they looked at the literature and they felt that was overuse of ICSI, and now we don't. But I think the hard part is that it's difficult to go backwards. It's hard to withdraw something that you did because you don't have the confidence it's working as well as you thought it was in your hands. But I would encourage people to look at, press their labs and say, is this really, really necessary?
Yeah. Are you still doing ICSI for PGTM?
That we are, yes.
Yeah, we are too, but apparently there have been some data that are emerging that are saying that even that is not necessary. I'm not ready to change on that front yet. I feel like the stakes are incredibly high, and I would have like much less of a threshold for error. All right. Well, welcome, Adriana. We know that you're usually behind the scenes, but I'm so thrilled that you're joining us today. And not only that, but we're putting you to work in a different way. We're going to have you discuss this next paper, which is really interesting. It's the Retrospective cohort study comparing successive medical management of early pregnancy loss in pregnancies conceived with and without medical assistance. Take it on.
Thank you, Eve and Kurt. So the paper that I'm presenting comes from first author Valeria Colaselli-Terscher at the Medical University of Innsbruck in Austria. The author's primary objective was to compare the success rates of medical management using mifepristone and misoprostol in pregnancies conceived with and without IVF, and after both fresh and frozen embryo transfer. They also sought to evaluate predictive factors of success, time to first passage of tissue, and time to complete resolution of pregnancy. This was a retrospective cohort study, and they included patients of a max gestational age up to 12 weeks and 6 days of pregnancy. Patients were either offered expectant medical or surgical management, but those with an allergy to either mifepristone and misoprostol or who had an IUD in situ were not considered candidates for medical management. The protocol for medical management consisted of 200 milligrams of mifepristone PO in the outpatient setting and subsequent admission to their day clinic after 36 to 48 hours for the administration of 800 micrograms misoprostol vaginally. It sounds like in Austria, they have day clinics, which is an outpatient setting where they can provide treatment and surveillance. Misoprostol was placed around the cervix by a physician during a vaginal speculum exam. And per the clinic protocol, the patients were monitored in this day clinic for an extended period. An additional 400 of misoprostol buccally was administered to the patients who were noted to have no vaginal bleeding or signs of impending passage of tissue after 4 to 6 hours, and this was based on the physician's discretion. All women underwent an ultrasound at the time of discharge from the day clinic to predict the success of treatment. They then scheduled follow-up in 1 week for all patients who were found to have a persistent gestational sac or an endometrial lining of greater than 20 millimeters. The decision to perform a DNC was based on the clinical symptoms or ultrasound findings concerning for retained products of conception, not purely based on endometrial thickness. They recorded the time of administration of medications, time to first passage of tissue, ultrasound findings before discharge, symptoms, surgical pathology, and whether the pregnancy was conceived with IVF, and whether it was a fresh versus frozen embryo transfer cycle. A total of 930 patients were included in the study. 99 or 11% of these pregnancies were conceived after IVF. The results were reassuring. The overall success of medical treatment with mifepristone and misoprostol was 89%, with no statistically significant difference according to the mode of conception. The success rate was 89% for both IVF and non-IVF pregnancies. A subgroup analysis of the IVF group showed no differences in the success rates between pregnancies resulting from fresh and frozen embryo transfers, with a success rate of 89% for each group. Since all women were evaluated with an ultrasound prior to discharge from the day clinic, it was found that the ultrasound diagnosis of completed abortion had a 4.5% false positive rate. 30 of the women who they thought had completely passed the pregnancy ultimately required a DNC for retained products of conception on the basis of persistent bleeding, ultrasound findings, or persistently elevated HCG in the setting of bleeding or retained tissue. Conversely, patients who were suspected to have an incomplete abortion on ultrasound because they were found to have an endometrial thickness greater than 20 millimeters, a visible gestational sac, or suspected retained products of conception were evaluated 1 week later. 45% of them were found to have completely passed the pregnancy at the time of their follow-up. The remainder were then offered observation, follow-up, or a DNC. Only 59 patients, or 25% of those who were identified as at risk for incomplete abortion based on their discharge ultrasound, went on to require surgery. Lastly, the authors also found that the mean time to first passage of tissue after misoprostol placement was 5 hours, plus or minus 2.1 hours, and there was no difference between non-IVF and IVF pregnancies or between fresh and frozen embryo transfer groups. Overall, this was a reassuring study which provides important data in a time where we see more ART-conceived pregnancies, but also more abortion restrictions. It's important to note that this was a unique study setting in Austria, where they have day clinics. As a result, the authors were able to predict the precise time to passage of tissue and the positive and negative predictive values of ultrasound findings on the day of treatment. The study protocol does involve more intervention and surveillance of medical management of early pregnancy loss than is generally done, but the study results are useful for counseling patients on what to expect if they were to undergo medical management at home. Secondly, I think that this study provides reassuring data that pregnancies conceived via IVF are suitable candidates for medical management. Currently in the US, mifepristone needs to be prescribed through REMS registered physicians. The study raises the point that mifepristone should be readily available at every IVF clinic should patients opt for medical management. Our hope as fertility doctors is to keep our patients in treatment, and we can reduce barriers to care by offering Mifi and Meso ourselves rather than referring the patient out to the family planning division or to another clinic. Curious to hear your thoughts on this paper. Do you guys tend to recommend surgical, medical, or expectant management for your IVF patients with an early pregnancy loss? And do you feel like this study will sway your practice at all?
I do think the study is kind of inspiring to really up my efforts to get access to be able to prescribe Mifi. Typically when we talk to a patient about different options, it's medical, surgical, expectant management. And I will say, I think most of our patients lean heavily towards DNC. And I don't think that's the wrong answer per se, but I do feel like perhaps there's more room for medical management. The other thing about this is, I think part of the reason they did this study is we do worry about placental abnormalities, and could abnormal placentation lead to more complications with expulsion. And I think the study does a really nice job of reassuring us to say, nope, there's really no difference and there's no reason not to offer medical management more frequently. I think emotionally, and this is where I spend a lot of my counseling on when you tell patients what to expect with medical management, the bleeding, the cramping. I just think so many of our patients are very fragile and take the approach of, I just want to go to sleep and be done with this. And I really respect that. I don't push medical management. It's really for the highly motivated patient who really wants to avoid a surgical procedure. But I think it does highlight the fact that meso alone probably is not sufficient, and we're not doing the best job that we can with medical management if we're just giving misoprostol in the absence of mifepristone.
Beata Seaver is a former fellow of mine. She's a lovely person, a great physician, and she's really taken strides in practicing over in Europe. And I think we've had lots of conversations about this, and I think it's the difference between medicine in Europe and the United States. There's a lot more hands-off treatment in Europe. There's a lot more only intervene if we have to, and it's clearly accepted by the patients over there. For whatever reason, it's whether we're treating our women differently or our women want to be treated differently. In the United States, it's I want it done as quickly as I can, and I want it done. I want to start tomorrow. Then most of the women I talk to, although I offer this, would prefer to have the surgical approach to end it soon. So. But the wonderful thing about this paper is it shows us that medical management does work, and we certainly can use it more often. And I would hope that we start recommending it more often. You've heard me advocate this all the time. Get off the treadmill of reproductive medicine, and start talking to your patient, and you'll probably find out that a lot of people would prefer this.
I agree. I'm going to jump in and just really quickly summarize one of the papers that was supposed to be Pietro's. So admittedly, I don't have a deep dive, but I think it's definitely worth highlighting. This next paper is called The Association of Duration of Embryo Culture with Risk of Large for Gestational Age Delivery and Cryopreserved Embryo Transfer Cycles. And just to put it out there, I admittedly had to remind myself what constitutes LGA. Average birth weight is about 7 pounds. And for all births in the US, 9% of all babies are LGA. And LGA is more than 4,000 grams or 8 pounds, 13 ounces. So really kind of a big baby. And so what the authors did in this study, it was a SART-CoRS database study looking at a total of 33,000 FET cycles in the study group had LGA out of a total of 181,000 patients looked at overall. So 18.2% of FET cycles were in the study group. And that resulted in LGA infants during the study period of 2014 to 2019. And I think the key finding from this study, and this is really why I wanted to highlight it, is the increased risk of LGA when the embryos remain in culture longer. So when the embryos were in culture for 2 days and transferred at day 2, there was a 13.7% risk of LGA. When they were in culture from 3 days, it was 14.4. 5 days was, 4 days was 15%. Day 5 transfer was associated with 18.2%. Day 6 was 18.5%, and day 7 had the highest risk with a slight increase at 18.9%. So by doing a blastocyst transfer, what these authors found was twice the rate of LGA than a medically unassisted conception. And granted, they didn't have a medically unassisted conception comparison group in this study, but looking at what's average. Looking at the increased risk, so they found that increased gravity parity, not surprisingly, increased maternal BMI, increased number of oocytes were also associated with LGA in this model. White patients who had a low BMI, this was considered to be protective. And interestingly, they found some, and I'm just going to couch this with notoriously SART data has a lot of missing data when it comes to racial data. And I think that this is also highly controversial. But they did note that Asian, Black, Hispanic, and combined Hawaiian and Pacific Islander were protective factors. So white patients did the worst in this study. And I think, again, it highlights that we have used cryopreservation, I think, incredibly liberally. It's been revolutionary in terms of reducing the risk of high order multiples, as we discussed earlier. It's been revolutionary in reducing the risk of OHSS. But are we trading off one issue for another? And I think that this warrants a lot of attention to look at culture and culture media, as well as conditions. And so I think in a large SART study, you just can't get that granular to see whether or not there are differences in how we're culturing these embryos, and could there be differences in epigenetic changes. And I think, again, the bigger question too is the long term, what does an LGA infant translate to when it's an LGA infant from ART? Is it the same risk that we think about in terms of childhood epigenetic changes, obesity, later cardiovascular risk factors? I think this warrants a lot of attention.
Yeah, I agree, Eve. I think this is showing, first of all, what you said was, I totally agree with it. Cryopreservation has revolutionized our field. I mean, we couldn't make many of the changes without it. But what this shows me is perhaps we're not, perfectly precise in the way we handle cryopreservation and embryo transfer, that there's some more work to do. It's encouraging that we're arguing on the margins here. These are relatively small difference in I don't want to say LGA is not an important issue, but perhaps I've heard my obstetrician's friends say it's less important than preterm. But anyway, we're not perfect. And this is just showing us that there's more work to be done, and we should understand this as a field.
Yeah. And again, I think it speaks to that idea of optimization, that's really, as I see it, really sort of the next phase of where we're going.
I have a couple great papers I want to talk to you about, but they're and I'm going to take the liberty of talking about them back to back. The first one is about endometriosis, the second one about adenomyosis, and they're both nice high-level topics here. So the first one by Sarah Olson, and a senior author that I can't pronounce, my apologies, is endometriosis diagnosed by ultrasound is associated with lower live birth rates in women undergoing their first in vitro fertilization ICSI cycle. And it's adding to the controversy of, in multiple ways, this paper is adding to the controversy of, first of all, does endometriosis affect IVF outcome? And secondly, how do we diagnose IVF? So the objective of this study was to look at the cumulative live birth rates in patients with and without ultrasound diagnosed endometriosis. Now, ultrasound diagnosed endometriosis is controversial in itself, but it's really gaining a lot of traction in Europe. They have something called an endometriosis ultrasound, which is more than a clinical ultrasound where they look for wonderful things like sliding of the uterus and peritoneal defects. It's a longer ultrasound than what we would do in our clinical assessment, and they're claiming very good sensitivity and specificity. Well, relatively good sensitivity and specificity with diagnosing this, but they feel very comfortable in diagnosing deep infiltrating endometriosis. So this is a paper that looks at those identified with deep infiltrating endometriosis versus those that don't have it. And they show in a cohort out of a tertiary care hospital in Sweden, looking at around 1,000 patients, that women with deep infiltrating endometriosis have a lower cumulative live birth rates to the order of around, it was 40%-ish in the whole cohort. And with endometriosis, it's down around 33% with a Crude's odds ratio of around 0.77 and an adjusted odds ratio of 0.63. So roughly a 37% decrease in pregnancy if you have deep infiltrating IVF. They do their best to control for many of the confounding factors you might imagine. This is a cohort study, so there's a lot of differences between those that have endometriosis and those that don't. But it adds to the literature that endometriosis does seem to affect the IVF process. Before I give you my opinions on it, they have a couple interesting theories. They do note that the lower live birth rate was lower despite having the same number of eggs and despite having the same number of morphology. So therefore, they hypothesize that endometriosis might be affecting the egg quality, which you can't see by morphology, and that morphology itself is only a crude measure of embryo competence, and that endometriosis might be affecting the embryo in another way than just what it looks like under the microscope. They also do note that there's a lower implantation rate, which more intuitively corresponds with my thought that endometriosis might have effect not only on the gametes, but on the endometrium as well. But I want to open this up to, you can let that sink in, that women with endometriosis have a lower pregnancy rate. I guess I would expect that if I saw someone that had, large endometriomas or deep infiltrating endometriosis, I would suspect they're a more difficult patient to treat. And this paper says that. But there are a lot of papers that they cite that say that this isn't the case. And there's still a debate today that endometriosis has no effect on IVF outcomes. And there's a camp of people that I meet at meetings all the time saying, how come whenever I look at my data, endometriosis is actually even better or at least equivalent? So this debate goes on and on and on. And it was one of my early papers that as a meta-analysis said that I really do think endometriosis affects IVF outcome. And there are other members, some of them are on our editorial board and associate editors that claim that ART fixes it no matter what. So it adds to the controversy. I will add one thing that I think is the fact that people don't get in this is that if you look at pregnancy rates crudely between these two groups, you see very good pregnancy rates with patients with endometriosis. And therefore, that can lead you to believe that things are really good. In this study, the confounding, again, was in the effect of making endometriosis look better. Let me say that again. If you look at it crudely, the rates are very close. When you control for factors, it makes endometriosis look worse. So if you didn't control for these factors, you wouldn't see the effect. That's a hard one to wrap my head around. That means that patients with endometriosis are otherwise better prognosis than patients without. And when you take that into account, the endometriosis does seem to have an effect. That's the opposite kind of confounding we see in most of our studies. I saw it in my study. I see it again in this one. So I think there's a lot to endometriosis that we don't know, and it isn't intuitive to us in just to our eye. So I thought this was a nice study. It adds to the controversy. You're going to see a lot more papers about the utility of ultrasound as a diagnostic methodology to endometriosis. Please look out for those, because I think that is going to help our field, even though it's not going to be perfectly sensitive and perfectly specific. That the fact that you don't need to do a laparoscopy is a huge benefit to patients. But I personally think endometriosis still affects the outcome, but ART is still the best treatment we have for these patients. So what do you guys think of that?
Yeah, I mean, I think you summed it up beautifully. And I think part of it is it's really heterogeneous, right? So ultrasound diagnosed endometriosis tends to be sort of the worst case scenario. And a lot of the studies that you had included in that original, I can't remember, 2006 meta-analysis also had laparoscopy as a diagnostic criteria. And maybe my thought process is that some of these patients who have laparoscopically diagnosed minimal to mild endometriosis may have better outcomes because they don't have the same diminution in ovarian reserve. And I think once you have large endometriomas, in so many cases, we're seeing low AMH, low response to gonadotropin stimulation. And so in a younger patient, they have good quality based on being younger, but they act more similarly to older patients. And so when you adjust for age, you are seeing that worsening effect. But I think that if we are looking at endometriosis diagnosed on ultrasound, as we are in this study, then you're probably capturing the patients that have the worst prognosis because their endometriosis is so obvious. It's all over the place. It's deep infiltrating. It's endometriomas. And I do think that on a single cycle, we may be seeing that. I think the real question that is not answered by this study is what is the cumulative effect of endometriosis looking at combined fresh and frozen. And my personal sense on this, looking at our data, is that these patients do much better in a low estrogen environment. And so when you do a fresh cycle, it's by definition a higher estrogen environment, unless you're using something like letrozole along with stimulation. And maybe that's a happy medium. But I find that a lot of the time, these patients with endo will do very well with an FET on a natural cycle or a letrozole stimulated cycle in a lower estrogen environment. And so I think this is definitely part of the story, but I think that unless you're looking at every embryo transfer that results from a single retrieval cycle, you're not quite capturing the real clinical picture and how to counsel patients.
I want to add a clarification to what I said before because I thought of better words. This confounding that I'm talking about is something called confounding by indication. It's the technical term. And basically what it's saying is that when we see a woman with endometriosis, we intuitively in our AI brains treat them differently. We treat them more aggressively. We treat them with different protocols. We change things. And ultimately that tends to work and we get a better prognosis. If you control for all of that, the impact of endometriosis is worse than it appears because we've already identified it and tried to take care of it in the way we handle it. So that's trying to give you a better explanation of this confounding that we see. So because we're good at what we do, most of the patients with endometriosis do well, and therefore we don't appreciate how much endometriosis can actually affect ultimately live birth rate. The next paper I really enjoyed reading is something also you're going to see a lot more of in the future. Connie Reese and Benedictus Schutt published a paper called Quantitative Ultrasound Measurement of Uterine Contractility and Adenomyotic versus Normal Uteri, a multicenter prospective study. This is a neat study. It's not going to affect your clinical practice today, but I'm really glad it's in Fertility and Sterility. And I probably have to thank Eve for that because Eve interviewed this author as a podcast when we were at the ESHRE meeting, and we, I'm sure, twisted their arm to put it in our journal instead of Human Reproduction. But basically, ultrasound assessed contractility is something you're going to see a lot of. The measurements have become good enough, or at least quantitatable, where people can now perform a very sophisticated ultrasound looking at peristaltic waves through the uterus. And this paper basically compares around 46 women with endometriosis to around 106 controls with a relatively sophisticated program that tries to quantitate uterine contractility. It does that by breaking it into something called amplitude, frequency, velocity, and coordination. Now, we could spend a lot of time debating these definitions, and I bet they will evolve over time, but essentially it's looking at not only the strength of the contractility, but its coordination between the anterior and posterior halves of the uterus. And they quantitate this across the menstrual cycle in the luteal phase, in the follicular phase, and around menses. And the trends overall are that women with adenomyosis have an increased amplitude in their peristalsis, but a decrease in frequency a decrease in velocity, and the authors point out perhaps, and most importantly, a decrease in coordination. Also, interestingly, when you have dysmenorrhea or high pain score, there's actually a decrease in frequency of contractions and a decrease in velocity of contractions, but there tends to be an increase in the amplitude. So they summarize the paper by saying that contractility differs in patients with adenomyosis compared to those across all aspects of the menstrual cycle. And this opens up some wonderful future hypotheses to be tested about differences in mechanisms about infertility in patients with adenomyosis and also differences in dysmenorrhea with patients with adenomyosis. It's possible that these measurements on ultrasound could be target therapeutics, and it's also possible they could be target diagnostics. It's a really interesting study. There's a nice editorial about it as well, claiming that, of course, it's interesting and preliminary. Yes, there's lots of minor problems with the paper about, did they really have adenomyosis? Where there were comparison differences. They try to control for differences like age and parity might change, many of this contractility. So don't consider this to be the definitive work. But I really enjoyed reading it, and you should too, because it's going to open up the door for lots of other papers on this in other aspects of infertility, fibroids, unexplained infertility. I mean, if this ends up to be a really good tool, there's a lot we can do with it. But I have to end with, it really does make me think about teleology. Are we finding things that correspond to what we think should happen, as opposed to these measures really are what is happening or really are the cause? I'm not saying disregard the paper. I'm just saying, there's been a lot of in our literature about trying to explain findings to what we think is the truth rather than having the findings leading us to an alternative truth. So just keep that in mind when you read very preliminary papers like this. So what do you guys think of this story?
Yeah, I mean, I had the same thought. And I will say it was really fun being at ESHRE last summer and seeing some of these data emerge and be presented in the earlier stages. So that was great. And you guys can look forward to another robust episode of Fertility and Sterility live from ESHRE this year as well. But I agree, and I think that it really opens up the door for what else can we think about and what else can we see on ultrasound. Ultrasound is getting to be much more refined in this idea of tissue resistance, the idea of peristalsis and contractility. I know there are some very old data looking at success of embryo transfer and looking at uterine contractility post-embryo transfer, and even some studies on acupuncture calming down the ultrasound waves. And I think that there's just so much potential here that it's an area of study that we previously really had not paid a lot of attention to. And so part of the reason that we had invited these authors to come onto the podcast last summer was exactly that. It was kind of a new area of study that I feel like has tremendous potential. So I think that this is the beginning. This is not the end of the story. This is the beginning of the story, and I'm really excited to watch it unfold.
Yeah, my thought was just, I would love to be trained on these different forms of ultrasound, and I can't wait to see the ways that these technologies develop.
Yeah, and a shout out to Elner Babiev at our center who's doing some of these studies. So I think it's really interesting. We have 2 articles remaining. One is a scientific article, and spoiler alert, one is a letter to the editor that I want to discuss with the editor. This next paper is really fascinating. It's called Unhealthy Air Quality Secondary to Wildfires is Associated with Lower Blastocyst Yield. And this was done by our very own Molly Cornfield with senior author Sasha Krieg from OHSU. And I think this is a really important manuscript highlighting the potential environmental impact of natural disasters on ART outcomes. Just to frame it, in the Portland metropolitan area in 2020, there were wildfires that led to widespread smoke plumes, causing acute onset of air quality emergency. And studies historically have shown a link between poor air quality and adverse reproductive and obstetric outcomes. And if you look at They looked at the average air quality in Portland in the preceding 2 months, and it was good, and it was 26. And just for those who are interested, on your weather app on your iPhone, it'll give you the AQI of where you live. Shifting winds caused skyrocketing in the AQI to as high as 486, which is hazardous. There was a 10-day period of time from September 10th, 2020 to September 19th, 2020, where the AQI ranged from 62, which is considered to be moderately bad, to 486. And then after those 10 days, the smoke rapidly cleared and air quality returned to normal. And so the authors examined the potential reproductive impact of this exposure on patients who were undergoing IVF. The primary outcome of interest was blastocyst development rate. And then the secondary outcome was the number of mature eggs, fertilization rates, and then the number of blastocysts obtained. For embryos that underwent PGT, they looked at whether or not those embryos were euploid versus non-euploid in a binary category. Patients were included if they had a retrieval date on or after July 29th, which was 6 weeks before the onset of the unhealthy air quality period. And they included patients who had an egg retrieval through September 16th, 2020, giving the retrieval patients a minimum of 2 full days of laboratory exposure. And they really broke this up, and they looked at 2 meaningful touch points where air quality may impact the IVF process. So one was the patient breathing the unhealthy air during stimulation, and they called this the patient exposed. And then 2 was embryos exposed to potentially impaired air quality in the IVF laboratory, and they called that the laboratory exposed. And there was some crossover in some patients who fell into both groups. And so in total, there were 3 groups that they compared: the unexposed before that period of time, patient exposed, and laboratory exposure groups. One thing worth noting is the manuscript describes the routine air quality control measures that their program uses. And I do think this needs to be a call to action for all of us, especially our learners, to learn about the systems we use in our own labs and to know how to optimize those systems. There are some different types of filters for different types of matter that can affect air quality. 3 of the main things that we worry about are microorganisms, VOCs or volatile organic compounds, and then particles. And wildfire is particulate matter. So different types of filters are used to capture each of these to provide clean air in the laboratory. In addition, there can and should be air exchanges between the lab and outside air with positive pressure forcing air out and not allowing atmospheric air in. And in this paper, they had between 2 and 4 air exchanges per hour. I don't know what's standard for Portland, and there are probably differences in recommendations for these air exchanges depending on the location of your IVF laboratory. In our program in Chicago, and thanks Joan Riley for sitting down with me the other day and going through our air exchanges, because I admittedly didn't know how many air exchanges we do, but our program is in downtown Chicago. We're in a high rise. We're on the 24th floor. And Chicago is a much more polluted city than Portland, but we have 15 air exchanges per hour. So I think one question that I have on this manuscript is 2 to 4 standard for Portland, or could the air quality in their laboratory have been different a priori? Their filters are changed annually, and they just happen to be changed prior to the wildfires. I would say most programs that I've been in change either twice per year or quarterly, but again, I've only worked in urban areas. Finally, their physicians and embryologists estimated air quality. It wasn't monitored, and there wasn't a robust system in place to assess particulate matter. And I think this is one of the weaknesses of the manuscript. They did a single measurement at one point in time, and the AQI was 125, which is pretty high for air inside an IVF laboratory. But nevertheless, let's look at what they found. So the number of included patients was small. They hypothesized a mean difference of 20% in blastulation, and so they were adequately powered to detect their differences. They had 69 total included patients, 44 that were unexposed, 16 in the patient exposure, and 15 in the laboratory exposure cohort. They used regression models to compare the laboratory exposed with the unexposed and the patient cohort with the unexposed. They controlled for age. They didn't control for AMH, which I would have liked to see them control for AMH as well. Demographic and cycle characteristics were not significantly different between groups. The blastulation rate in the lab exposure group was 50%, so really pretty good, compared to 59% in the unexposed group, and this was not statistically significant. There were no differences in oocytes retrieved or fertilization rates. The main finding was that the IVF cycles in the laboratory exposed cohort had significantly fewer blastocysts than cycles without exposure. And this was a difference of 2 blastocysts. So range of 0 to 14 with 4.5 blasts compared to 2 blasts. So, arguably a pretty meaningful difference. And that the exposed cycles were more likely to have no blastocyst available for freeze or transfer. And when you look at those numbers, so 3 of 15 patients, or 20% in the exposed group, had no blastocyst available for transfer or for freezing. And I think this is what contributed most to the overall lower numbers of blasts between the groups. And so they really attribute this no blastocyst development to poor air quality, stating that even though there were no differences in blastulation rate, fertilization rate, that the absolute number of blastocysts was different because of this particular risk associated with poor air quality. And again, I think it's really interesting. I do wonder how much was really due to poor air quality in the lab, given the limitations. I would have loved to see those patients who had no blasts, like how many eggs did they have? What was their AMH? With low numbers, did that just skew the data? Were there poor sperm quality issues as well? But I think it's really thought-provoking. I think more than anything, it's a call to action to pay attention to air quality in your lab, both every day, but especially in situations with poor air, like high air quality indexes, and maybe consider self-regulation or internal pauses in treatment where applicable in your own centers until air quality can be optimized. And so I love this paper. I think it's really interesting, and it has flaws, but I think that we need to pay attention to it.
I love papers that show that natural occurrences, natural disasters, and things like that can really affect reproduction. And then our world, like an IVF lab, is a microcosm of that. We can actually study some of the mechanistic actions of it. So it was fun to see that. Fun is the wrong word. Interesting to see that all of these things we take for granted about protecting our lab can matter. But even, the other thing we can't discount is that these people are breathing this air outside of the IVF lab as well. So, it certainly can affect. Years ago, a good friend of mine who was also a fellow at Penn, Steve Spandorfer, when he first moved to Cornell, was right before 9/11, and he never published it, but he had a wonderful slide presentation about IVF and miscarriages before and after 9/11, which was encompassing, obviously, all of Manhattan, and it really had a dramatic effect. And we've had lots of conversations. Was it the IVF lab, or was it stress, or was it the human body? But clearly big things like this can impact fertility. So we just happen to be taping the day of the solar eclipse. So I wonder if the solar eclipse today will affect the pregnancy rate. Maybe we can see a blip on that, and we can talk about that in years to come too.
No, but daylight savings time does. Spoiler alert, there's some data that are going to be presented at ASRM this year. But yeah, right. The IVF laboratory is a microcosm, but you can't take the patient factors. You may be able to control the lab, but you can't control everything that, goes in. All right, Kurt, we're going to end on this, and this is a little uncomfortable, but I really want to highlight it because I think that I think that everybody should read this letter. I'm not sure how I would have felt if I was in your seat as the editor-in-chief getting this letter. I can tell you how I felt as an ASRM executive board member who is so proud of the new, more inclusive definition of infertility. And for those of you who are listening who may not be aware, ASRM really broadened the definition of infertility to include those that don't have the necessary parts or gametes to reproduce, which is really basically means that LGBTQ patients, single patients, patients that don't have sperm for one reason or another, should be treated as infertile and should be granted access to insurance coverage for infertility where applicable. And so this was a letter to the editor written by 3 authors from Singapore, the Republic of Congo, and Malaysia who argue that the new ASRM more inclusive, and they put in quotes, more inclusive, which I'll leave it at that, definition of infertility is rooted in what they call out as Western secular liberal ideas that conflict with traditional conservative religious cultural values. They state that ASRM's more inclusive definition will impact patients, the general public, and that it will be particularly problematic for medical professionals with strong religious beliefs who may face civil liabilities and lawsuits if they refuse to facilitate, again, in quotes, unconventional family formations by fertility treatment. They call for the addition of an exclusionary clause similar to that for physicians conscientiously refusing to perform abortions. They conclude by saying that the more inclusive definition is targeted domestically and may find little acceptance at the international level, particularly in Islamic and African countries that oppose LGBT rights, and therefore the definition lacks multicultural sensitivity towards various diverse ethnic and religious communities. I just want to share my views, and then Kurt, I want to hear what you have to say. Personally, I don't respect their views and I don't agree with them. I'm really glad you published this, but I think it's an offensive letter personally. And as a proud ally of the LGBTQ community, I had a very visceral, emotionally negative reaction to this letter, as you can probably tell. I commend ASRM's more inclusive definition, and instead of creating an exception, I think this should be the standard of reproductive care worldwide. Personally, my thoughts are that if you hold deep biases and you believe that only men and women should be allowed to build families and you would withhold care from anyone outside of that, I would go so far as to say that I don't think you should have the privilege of being a reproductive endocrinologist and infertility specialist. I encourage our listeners to read this, and I'm encouraging everybody to write a response to the authors and flood Kurt Barnhart's email inbox with this. All right, Kurt, what say you?
I'm glad we received the letter because, this is what a letter to the editor and the journal are supposed to do: start a discourse and share beliefs. I mean, certainly I felt very strongly it wouldn't be fair to censor this and not share that many people have this beliefs. But, it's funny that as we started the podcast, we're confusing science, medicine, and politics and belief. This is a scientific journal, and ASRM is a professional society, and their definition of infertility is correct. That is infertility for all of those reasons. If you want to say, I don't believe that I should help those people for various other reasons or beliefs, then fine. But that doesn't mean the definition is wrong. That means your beliefs are not centered around the science of infertility and the treatment. So I'm not going to argue politics here, but I agree, talking to Eve and many of the people who responded to this letter, that they responded correctly, that this is our definition of infertility. If you have different beliefs, then you can have different beliefs, but you can't have different science. So we'll leave it at that.
Perfect. It's exactly right. I think that sums it up so beautifully. But again, I encourage everybody to respond and flood the inbox. Kurt, for those who want to write a letter to the editor, how do you go about writing a letter to the editor?
So thanks for the softball, Eve. There's 2 letters to the editor. to give you a little history, Fertility and Sterility stopped publishing letters to the editor for about a decade, and that had to do with other decisions about page limits and things like that. So letters to the editor are now back, like in many journals, and they should be a letter about an article in Fertility and Sterility. And there's a time limit. We don't want you to comment on a letter. On an article 3 years ago. So it gets sent in like any other publication. It's reviewed and sometimes revised, like this one was, by the way, multiple times. And then it should be shared with the scientific community, and the author of the paper in question gets a chance to respond, and they don't always do. But by the way, there's another way to comment. There's a whole section called the webpage where you can comment with what's called a consider this piece, where you can expand your theories and your provocative thoughts in a 1,500 word paper, or sometimes even longer. And you can start a conversation about that as well. So traditional letters to the editors are there, but there's also other forms on the Fertility and Sterility website to express your opinion, and we encourage you to do so.
We encourage everyone who's listening to like and subscribe to our podcast if you are not already subscribed, and please rate us, but only if you're going to rate us a 5. And we have 3 journal clubs in March on the new subchorionic hemorrhage guidelines, 2 versus 3 year fellowships, and the SREI white paper, as well as the cost effectiveness of PGT. So please log on, listen, register, and engage with us at Fertility and Sterility.
This is always a lot of fun. I enjoy it. Eve, Adriana, it's wonderful to talk science with you. I hope you all appreciate our comments. And if you don't, write a letter to the podcast.
This concludes our episode of Fertility and Sterility on Air, brought to you by Fertility and Sterility in conjunction with the American Society for Reproductive Medicine. This podcast is produced by Dr. Molly Cornfield and Dr. Adriana Wong. This podcast was developed by Fertility and Sterility and the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While the podcast reflects the views of the authors and the hosts, it is not intended to be the only approved standard of practice or to direct an exclusive course of treatment. The opinions expressed are those of the discussants and do not reflect Fertility and Sterility or the American Society for Reproductive Medicine.